Good afternoon and welcome to the fourth NorthShore Outcomes Research Seminar and our COVID-19 research series. Today, Dr. William Trick will be joining us to present evaluation and response to the COVID-19 pandemic for the region's most vulnerable populations. We will also be joined by an expert panel, including Dr. Robert Weinstein and Dr. Michael Lin from Rush Medical College and Dr. Tony Solomonides from NorthShore. Next slide. Thank you. I would like to take a moment to thank our first responders and all those working on the front lines during the pandemic. I'd like to thank our Director of Outcomes Research Network, Dr. Bernard Ewigman, the program directors and NorthShore leadership and the research staff for making this seminar happen. And also I'd like to introduce myself. I'm Dr. Sean David. I am the program director for Translational Science and Outcomes Research at NorthShore. And our facilitator is Rabia Ali, who will be guiding us through this seminar. And Rachel Brewington is involved in a supporting role in this seminar as well. So the NorthShore Outcomes Research Network is structured with key academic leadership that's transdisciplinary, and it provides support to catalyze research across NorthShore University HealthSystem, as well as with our Institution for Translational Medicine academic communities and across and other CTSA communities across Chicagoland. Our goals are to enable uniform community access to care that is effective, efficient, and equitable, to enrich the practice of medicine for the providers, and to support some key strategic clinical quality and operational decision-making in our own health system. The objectives of our seminar series are really to promote the flourishing of our principal investigators, to disseminate the research activities and resources to the research community, and to promote a culture of collaboration and team science. We want to bridge together researchers to their peer community across Chicagoland, and also ultimately to deliver outcomes research that demonstrates improved patient and population health outcomes for our communities. Next slide, please. And now I'd like to give this to Rabia.
Thank you, Dr. David, and hello, everyone. So in today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the incubator help discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by just hovering your mouse over the bottom of your Zoom screen. I'm sure many of you are familiar with this, given everything has gone virtual these days. But also please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose to message either the panelists or the speakers, and this would include myself, or you can choose to message everyone on the webinar. If you're experiencing any technical difficulties, please let me know by messaging all panelists, and I'll assist you the best I can. I'm just going to go ahead and hand it back to Dr. David, who will go over the agenda for today. Next slide, please.
Thank you, Rabia, very much. So just to go over the agenda for today, we have until about 3:10, a little before, for the introduction to the speakers. This will be followed by the lecture from Dr. Trick, Evaluation and Response to COVID-19 for the region's most vulnerable populations. That lecture will run until 3:40. We'll have 10 minutes for Q&A, and we will derive questions from the comments. So please feel free to put comments, questions in during the talk, using the chat function. And then at 3:50, we have an incubator hub expert panel. So we will be joined by Dr. Weinstein, Lynn, Solomonides, as well as Dr. Trick. And we'll go over 4 discussion questions addressing implications for health equity for dissemination and implementation science, policy, and future translational research directions. And we want comments from the participants, so please add comments to the panel as well, and we will introduce those. And after that, we'll have some closing remarks. Next slide, please. So it is my pleasure to introduce today's speaker, Dr. William Trick, who is Director of Health Research and Solutions at Cook County Health. Without further ado, I would like to hand it off to Dr. Trick to start off the presentation. And
Great.
thank you very
Great.
much.
Yep. Thank you, Sean. Thank you, Rabia. And thank you, Rachel. It's my pleasure to present today. I will first talk about the epidemiology of COVID, the epidemiology of other public health crises that we've had in the region, and then transition to some field work that we've done on some vulnerable populations. And so it would be less about some of the research, but certainly we think that some of this work leads into research opportunities. So next slide. So the first slide is going back to May when we were in the midst of the pandemic. And this is a slide from the New York Times that highlighted which populations were getting sick from COVID. And so if you look at the slide of the United States and see the brighter red areas are Black/African American populations. The yellow color denotes those counties that had predominantly Hispanic cases. And then the dark purple were the Native American population. So you can scan the United States and see that just at a quick glance, there was a disproportionate impact on Hispanics and Black African American populations. If you look at Illinois, you just see in that corner of Illinois was really predominantly Hispanic, where we saw most of a disproportionate number of cases. Next slide. So why does this occur? In 2008, there was an article published in Emerging Infectious Diseases that laid out the theory as to why there are disparities during public health crises. And this was 1 year before the influenza pandemic when this was laid out. And they talked about various domains as to why you will see disparities in impact on pandemics. And this was particularly around infectious disease pandemics. So the first domain that they described was differential exposures, and things that we now feel like are explanations for what happened during COVID. It's neighborhoods with a lot of crowding, in which the occupations are such that people are close together. They're not allowed to work remotely. All the work has to be done on site, and frequently rely on public transportation to get to work, or any kind of transportation. So they quoted that people who work at home during 1999 and 2005 were people able to work at home. 82% of those were white. And that among riders of public transportation, 63% are minority. Another domain was distrust of government, which often plays out in terms of lower vaccine coverage. And it's a harder to reach population with messaging sometimes. Limited access to medical care, and also susceptibility to complications due to chronic diseases. And we see that diabetes and obesity in particular are higher among Blacks and Hispanics. Next slide. So in follow-up to this, during the pandemic, there was a survey, a nationally representative survey conducted, published in the American Journal of Public Health, that took Blumenstein's theory from the prior slide and asked these questions and divided the respondents up into 4 groups: non-Hispanic whites, non-Hispanic Blacks, Hispanic that preferred English, and Hispanic individuals who preferred or were Spanish speaking. And when you see the column on the far right, Hispanic individuals that preferred Spanish, almost half had less than $25,000 a year in their annual income, almost half an education less than high school, 3/4 had children at home less than 18 years, 75% said they were unable to work at home, and over half again had no sick leave in their job. They created an index to look at whether you could physically distance at work, and the index was highest, so you got a point for various barriers to being able to physically distance, and it was much higher again among Hispanics, those who speak Spanish, and the household mean was significantly higher than others. As a continuation of this, on the next slide, you'll see some other factors that Quinn looked at. And you see kind of the same pattern with non-Hispanics whites as the referent, and the number as the adjusted odds ratio, adjusting for age, gender, sex, presence of children, education, and income. Spanish-speaking Hispanics much more likely to have daycare in the groups in a group setting, much more likely to have difficulty avoiding public transportation, and much more likely to report discrimination when seeking health care. So all these factors that were proposed as theory in 2009 were substantiated through this survey. And then in the next slide, you'll see what happened to Chicago in 2009. So the influenza pandemic disproportionately impacted Hispanics and non-Hispanic Blacks at a ratio of 4 to 4.5-fold higher than non-Hispanic whites. Another pandemic or public health crisis that behaved a little bit differently, and you go back another 24 years to the heat wave in 1995. So on the right's a picture of Chicago, and it's nostalgic in how Chicagoans can beat the heat by opening the fire hydrants. That was a time when the heat wave or the heat index went up to 120 degrees. If you look on the left, you see the spike in the heat index, the spike in the temperature, and a subsequent increase in mortality associated with that heat wave. And there have been a couple of very in-depth sociological analyses of the heat wave and who was impacted. Turns out that it was the elderly, the African-American population, and those in socially vulnerable neighborhoods. Next slide. Kleinenberg was one of the first to publish his in-depth sociological analysis. And there's a quote from that in that he says that vulnerable, isolated people tend to live in places that foster social withdrawal, neighborhoods devastated by commercial abandonment, population loss, and violent crime. And so this is a little different than an infectious disease pandemic, but is still important for the work that we do, and that certain neighborhoods are predisposed to poor health outcomes. Next slide. One of the anomalies that was pointed out by Kleinenberg and Browning was an area called Little Village, and this is a map of Chicago with the red section representing the Little Village neighborhood of Chicago. And it's characterized by a high population density, a thriving neighborhood commerce, a very dynamic social ecology, where people can get outside, which was and be looked after by neighbors. And it was particularly important for the elderly. So next slide. When I think about these situations and how the health is impacted by those around you, it took me back. Instead of going for the older quotes like "No man is an island," I went for a more modern quote from Sun Microsystems in 1984. This commercial cut gets into my mind that the network is the computer, which of course he was right. It was crushed by Microsoft because Bill Gates was a better businessman, I believe. But it makes me think about our health in the next slide, and that the network is really your health. And it's true not only in these pandemics, but increasingly clear as we look at other health conditions. Next slide. So now transitioning to COVID, I've highlighted the neighborhood areas on the left that depict the heat-related mortality. So the dark black neighborhood areas are those that experience the highest number of deaths. The gray were in the middle, and then the white, the lowest number of deaths. And I've circled the Little Village neighborhood, and then put next to it the map of COVID-19 mortality from May from the Chicago Department of Public Health. And you can see that that same neighborhood experienced a disproportionate number of deaths due to COVID-19. So that which was protective during the heat wave was not protective during COVID, and probably or possibly increased their risk. Next slide. So when I looked at our data, this graph shows the cases that we experienced over time. So at the timeline on the left, you see the beginning of, or the mid-March, where we started seeing our first cases. And then it shows the proportion of each racial group. So the gray is a confidence interval around lines for, on the very bottom, the dashed line is whites. The solid green line shows the case rate at Cook County Health for Hispanics, shows a dramatic increase over time, and then plateauing at around 3/4 of our cases. And then Black, African American, and the blue dashed line at the top, showing that the proportion dropped as the proportion of Hispanic cases went up. As a reference point, I put in two vertical lines. One was the stay-at-home order that happened in mid-March. And then there was a website that tracked mobility and showed that the nadir, our best reductions in mobility, happened toward the end of March. And I suspect that had an impact on many populations, but obviously not the Hispanics. And quickly, I put in a couple arrows showing what the mean is for influenza. So in 2019 and 2020, most of our influenza, or the highest proportion, was in non-Hispanic Blacks, followed by Hispanics. And this is true. As I look back 3 years, I show one season, but this ratio is pretty similar. So COVID-19 behaved differently than influenza for us. Next slide. This is visually depicting what I just described to you in terms of the cases of Hispanics. So on the left is the density of Hispanics residents within each census tract. And I've circled some areas that correspond to the cluster analysis that was done on the right side. So the other map shows hot areas, and either red or the salmon colored areas are the hot areas where census tracts had high case numbers. Red, it isn't like a heat map where red is more cases than the salmon. It's just that the salmon represents it's a high area within a cluster of other high areas, whereas red is more of an area, a hot area with kind of cool or lower rate neighborhoods surrounding that. But you can see in the corresponding graphs that Hispanic neighborhoods really did kind of heat up in terms of our cluster analyses. And again, this is going back to May. Next slide. So we also looked at, combined the American Community Survey census tract data, mapped all the patients to their census tract, and assigned ecological variables to the to that census tract. And so what we found, so this is all Hispanic patients. It's all hospitalized Hispanic patients. And we compared those who had COVID during the 2019-2020 influenza season to those who had influenza during that same season. Of course, COVID coming in later, starting in March, and influenza dying off at that time. But the census tracts differed significantly. Similar to what Quinn found, that we found that the census tracts, you were more likely to have COVID if you were from a census tract where the Spanish was preferred over English, a higher proportion of Hispanic residents, non-citizens, residents with no high school diploma, a census tract with more manufacturing jobs, and also with a higher proportion in overcrowded situations. Next slide. So that was then, and now we're in a different time, and it made me think back to the one of the domains that contributes to pandemics and certain populations, and mistrust in government. And so this was taken, this is from the, I think this was, I apologize, I believe this was New York Times also, and it updates weekly the hotspots in the United States. This is a traditional heat map. The colors don't represent certain populations, but just hot areas. And you really see in Utah, where this picture was taken, high rates, and you see high rates in northern Wisconsin and the probably going into the Upper Peninsula. And then the picture is very instructive with this idea of mistrust in government. And I thought it was kind of like a Find Waldo. You see the guy with the mask in the middle, and you see the one empty seat next to kind of the forlorn looking guy wearing a mask. But this, I think, represents the current status that the pandemic has and probably will soon move on, and we'll see different populations impacted. Next slide. So now I wanted to highlight two of the interventions, field interventions that were done. One is a medical respite center that was set up by Dr. Keiki Hanami and our Director of Housing, Christine Haley. And then I'll go to substance use treatment. But first was our homeless response. Next slide. To start this off, I'll show you some data that was taken from the Capricorn Network. And one of the reasons I'm presenting today is my connection with Tony Solomonides, who sits on the steering committee for the Capricorn Network and has been there, I think, since day one with me. And one of the analyses that we did is to take the clinical data from 6 of the area healthcare institutions and join it to the homeless management information system data. And through that, we're able to look at how the prevalence of diagnoses varied by homeless typologies. And so the vertical dashed line is our reference group, and these are formerly homeless individuals who've been placed into stable housing. The red circle represents the point estimate for those who have no stable housing. And then the most interesting population that I think from this were the green triangles. And these are individuals who have an ICD-10 code of homelessness, but who are not receiving homeless services. So these are the people who we see often cycle between our emergency departments, and they're not plugged into any system to try and find housing services for them. And oftentimes that means shelters as well, because the shelters register people in the homeless information systems. And so I put a red rectangle around what we call behavioral health conditions. So the medical conditions generally were higher among that population. But then when you hit the behavioral health conditions, much, much more prevalent: bipolar disorder, depression, anxiety, cocaine, and alcohol substance use disorders, and schizophrenia. And so what we were left with COVID, so we did have the outbreaks within the homeless shelters and the congregate living situations, but we also had individuals coming into our hospital and other hospitals in the region who had no place to go, and were not plugged into these shelters. Next slide. So the medical respite is a term of housing for those who are typically in a shelter on the streets, develop a medical condition or some in a socially unstable environment. They have their crisis, they're sent to medical respite, and that is typically a transition then to stable housing. And so it's post-acute care to get people out of the hospital, but they're not safe on the streets, they can't take care of themselves. And then we hope to transition them to stable housing. Next slide. It was pretty Herculean what was done over time, and it was our group, but it also involved a lot of departments in the city of Chicago and the YMCA, which provided the location, and the Salvation Army. And so this was that long acronym. It was the Southside Y Medical Respite Site. Public health contributed from the city, provided PPE and citywide coordination. The emergency management provided cots, towels, laundry facilities. Salvation Army provided meals. The public libraries provided transportation. And family and support services provided some of the shelter staffing. And at Cook County Health, we had volunteer medical staff, provided the medical equipment, clinical services, the management and operations for the respite center. Next slide. This is what it looked like. If you look on the bottom left is the large room with cots for individuals. And so this was for people who had COVID, and they could be transferred from a shelter that didn't have a place to stay, about half from shelters and about half from regional hospitals. And so rather than house somebody in the hospital, which we were overwhelmed, as were most hospitals during this time, with inpatients, it was a way of moving people out of the hospital and into a place if they were medically stable. And there was supervision to check their oxygen and make sure they didn't become unstable during their stay. Next slide. These were the services provided. So as someone came into the respite center, they are entered into HMIS, the Homeless Management Information System, to start the process of housing services. And Medicaid application was initiated, a care coordinator was established, and they were offered a medical home within the Cook County Health System. The medical services provided, there is 24/7 nursing, daily medical surveillance. Telehealth was provided 7 days a week for primary care, and prescriptions were delivered by Provident Hospital. The behavioral health service was important, and we had telehealth substance use treatment and mental health counseling, on-site recovery coach for those with substance use disorder. Methadone was delivered to the site, and they were provided Narcan and education before they left. Next slide. When we looked at our population, I believe there was a total of 51 with 49 characterized here, most of which had come through our health system at some point in the prior 2 years. We compared that to the Z59, which is those diagnosed as homeless in our health system. And they were fairly similar with 1 in 5 having been through Cermak Health Services, which is our jail, 60% having been in our emergency department, about 1 in 5 being hospitalized, and 40% having been in a primary care clinic. And so, very rare that they were given behavioral health services. And so you see, as you probably know from anecdotal experience, is that the emergency department is often the place of care for these individuals. Next slide. So this just points out again the high rate of mental illness, looking at the clinical classification system and the categorization. And so 71% were identified as having a mental illness category from our codes. The on-site assessment thought that 10 more had mental illness based on their medication use and behavior. Next slide. So this is our social media, our Yelp feedback. What did people think of it? So we're happy to say 74% thought what you saw was excellent care, an excellent place for them to stay. And a few quotes: everyone was professional and acted like they care. Another was, would have liked to have stayed longer. Next slide. These are a mix of volunteers and staff that came and helped out with. In the right center is Dr. Hanami and Christine Haley. Next slide. So as we started to enter this second surge, you might be aware of the survey that was publicized in the prior month, which interviewed 4 cities throughout the United States, Chicago being one of those. And you see the dramatic, the serious financial problems that have impacted half the people in Chicago, but disproportionately, again, Black and Latino. And when you look at those having problems paying their mortgage or rent, it's roughly a third of Black or Latino families. And so I bring this up in the context of the new surge. And if people are unable to stay in their houses, then we'll be dealing with a new homeless population. Maybe not those that we saw the first time, but the newly homeless from the financial fallout from this. Next slide. So the last kind of field activity I wanted to describe was telehealth access for substance use disorder. And Julie Nowinski-Konchak really leads that for us here at Cook County Health and did an amazing job with this. And so I wanted to provide some slides of her work. Next slide. So during COVID, kind of the bad things that we see in terms of substance use treatment is that the residential centers shut their doors for fear of transmission within them. So it made it more difficult for people to get residential treatment. COVID, it was on NPR yesterday. I was hoping they'd say the same thing that I put in this slide, but there's a decreased supply of heroin, which has increased the risk. So you probably also have seen in the news that opioid use disorder has gone up, and the mortality from illicit opioids has gone up as well. And so there are 2 things that have happened. One is there are more adulterants as the supply has been a little more difficult to move across borders. The other is people have transitioned to easier to supply more potent agents, easier to transport agents like fentanyl analogs, which roughly 3/4 of our deaths in Cook County have fentanyl in their system. There have been some good things. The good is that there's been relaxation in the home delivery of medications. Methadone clinics are now providing a take-home supply where an individual had to show up daily to take their methadone. They now can be given a longer supply. And because of the emphasis on telehealth, we have partnered with the Chicago Recovery Alliance, and as you mentioned, saw the Southside Y Respite Center to reach people through telehealth. Next slide. These are where our MAT, or medication-assisted treatment referrals, came from during the first 4 to 5 weeks of the pandemic. We still got most of our referrals come from CIRMAC, or the jail, our inpatient setting. And so you see the blue are people that showed up, and the orange are, the total number of referrals but didn't complete their intake assessment. And we had quite a few self-referrals as well. And those people tend to show up. Next slide. And this is our MAT patients. And so where we were seeing on average about 500 individual patients for each month in January, February preceding the pandemic, we see that increase over time, and now are serving over 600 individuals with MAT. So whereas most of, I think, our appointments and our care dropped off during the pandemic, we've seen an increase through use of telehealth. Next slide. So I didn't want to leave this without saying that in response to the pandemic or pandemics, on the left you see the cooling centers, and that was from this past summer. And so this is a response to hopefully provide in neighborhoods that need such respite from the heat. They have station cooling areas, and often in those neighborhoods that we saw impacted by the heat wave of 1995. The other is that there really has been a focus on social determinants of health, and Mayor Lightfoot announced a $35 million investment in finding rental housing and subsidies for Chicago homeless. That's in the past year. And as I mentioned, the barriers to addiction care have fallen because of COVID-19. And hopefully some of these changes will persist. Next slide. So I want to acknowledge, I think, people I've already mentioned, and then the panel who are joining us in the next few minutes, Drs. Lynn Weinstein and Tony Solomonides. Thank you.
Thank you so much, Dr. Trick. This was a really fascinating presentation. The public health efforts you've made during the course of this pandemic, I'm sure have really set a high bar, especially focusing on such important health equity issues. So at this time, we can take a few questions from our listeners. As stated earlier, please input your questions in the chat box by addressing it to the panelists and attendees so everyone can be involved. And if all questions are not addressed, please feel free to contact Dr. Trick at his email shown on this screen. So I'll give everyone a few moments to enter their questions, but I do see one that was put in the chat box. Rachel, if you don't mind going back to slide 19, it should be of mapping COVID by density of Hispanic residents. Yes. So the question is, there were a few spots on the map where you would expect to see more cases, such as Humboldt Park, but there were not a higher number of cases. Do we know what the difference is in those areas compared to those areas with high numbers of cases?
Yeah, I think one of the limitations of this is that it's not adjusted for our catchment area, which is a big concern when I put this together. And I still worry that even though I think it does demonstrate that what we saw in the prior slide, and it's a nice, pretty graph, I still worry about not having a denominator, and that a population analysis would be a better analysis. I can't immediately pick out Humboldt Park from this, so it's hard for me to know if it's the blue within a red. I, at one point, painstakingly tried to match up some of these census tracts, and some of those blue were areas that do have a higher proportion of African Americans. If you look at the little, there's like a trapezoid kind of on the left, light blue, that is blue, dark blue, meaning it's a low neighborhood and or surrounded by hot neighborhoods. Some of those line up and were pretty remarkable, but it is hard to line that up. And again, the population's a problem. So I'm hesitant to say Humboldt Park was not impacted.
Thank you, Dr. Trick. Yeah, I can see it is a little hard probably to match up the different neighborhoods to what's on the map here. Does anyone else have any questions they would like to input in the chat box? Please feel free to do so.
Yeah, I have one, Dr. Trick. That's an amazing, inspiring, heartbreaking, and heartwarming presentation all in one. It's amazing what your team has done. The data you showed for Humboldt Park and elsewhere, were these incidence data, or did you also assess mortality and hospitalizations with the same kind of cluster analysis?
Yeah, so when I looked at Hispanic patients, I first looked at all patients and saw that it was, as you saw in the graphs, that it was predominantly Hispanics in our hospital, and I focused on hospitalization.
Okay.
We did look at mortality. I did compare mortality between race, and my recollection is there wasn't any significant difference. We have, as you saw, pretty small number of white patients to compare, so it was pretty much Hispanic to blacks. But mortality from influenza, as you probably expect, I don't think we had a single case that died this year, but COVID, we had many deaths.
Thank you. Okay. So do we have any more questions before we go to the expert panel? Okay. All right, hearing none. Rachel, could you advance to the next slide, and feel free to continue to enter comments or questions into the chat for our panel. So for our next segment, I would like to introduce our three expert panelists who will provide some additional insight to the implications of the research presented. First, we have Dr. Robert Weinstein, professor for the Division of Infectious Diseases at Rush Medical College. Dr. Michael Lin, also from the Division of Infectious Disease at Rush Medical College. And Dr. Tony Solomonides, the Program Director for Outcomes Research and Biomedical Informatics here at NorthShore. I can't do you justice to your very impressive CVs, but I would like to take a moment and thank you all for being here. And we also have Dr. Trick available for the panel. Next slide, please. So we have 4 discussion questions for our expert panel today. The first question is, what are the implications of this research for health equity? And I'd like to open this up to all 4 of the panel members, including Dr. Trick, and also comments are welcome from the participants. So, Dr. Trick, clearly there's quite a lot of implications for health equity. I think that was one of the clear goals of the overall work that was done. What are your thoughts going forward about health equity and some of the interventions that we can that are transportable to, into the future?
Yeah, I go back to the what I'd say was a prescient article of by Blumenschein in 2008, saying why is this going to happen, and now we see it happening in probably catastrophic proportions that we didn't anticipate back then. So there are really so many areas and so many that fall outside of the domain of traditional healthcare. It really is public health and beyond public health, policy solutions. So how do you create a work environment that's safe in the middle of a pandemic when we can't completely shut down what we recognize as essential workers? There are some things that seem obvious, none of which are easy, but having sick leave so that people don't have to show up to work sick. Providing break rooms that are safe, where people can get together. Providing a safe work environment. I mean, I could go on. I feel like I don't want to take another 10 minutes, but how
Oh,
do you
you
get
have
the
time, please.
message? Yeah, how do you get the message to the Spanish-speaking population? Was it that they were not uh, being reached by the messages, or do they hear the message, but is there a lack of education to understand what's being described? I think I'll stop. I've had many conversations, I know, with the panel about some of these issues, and want to highlight that Bob or Dr. Weinstein was bringing up these parallels to the heat wave and how there were differences that I dug deeper into and was fascinated by. So I will turn it over to them, and if there's silence, I can keep talking.
I can comment. It's Bob Weinstein. I think one of the challenges is kind of like the proverbial building the plane while you're flying it. The epidemic has come in waves, and by analyzing the first wave or two, first or second surge, Bill has demonstrated some of the inequities and problems with healthcare, particularly for the Hispanic Latinx community. And I guess the question is, how can we in real time fix some of those so that the next wave doesn't have the same disparity? And are there things that we can do, with brainstorming and thinking about? He mentioned messaging, but beyond that, how could we fix things? And we can measure it in real time and actually see with what's working and what doesn't, and will inform both the current surge, which is coming and is already here, and will inform future epidemics and pandemics. So I wondered what the other panelists or Bill think about what we could try to implement now, and what processes we could use to figure out what to do, and then what we could do, and then how we will measure it. And can we develop a correctional plan which would focus on itself and on the results, and improve the activities based on real-time rates of cases?
Yeah, this is
Indeed.
Mike. Oh, go ahead.
Mm-hmm. Oh, please, Dr. Lin.
Okay, well, I think Dr. Weinstein's laid it out nicely that we don't have the luxury of months. We really have weeks to go in terms of where we are in the second surge coming, and or some could argue we're already in it. So I think the things from my standpoint that are doable on that time scale would be, I think right now there's a lot of efforts to roll out contact tracing. I think I can say that at Rush, and I think in multiple institutions that are partnered with public health, that's an active discussion right now to figure out how to train up contact tracers to really focus on high-risk areas. And I think a lot of the work that's being done by Bill Trick and others to identify hotspots by census tract and zip codes are immensely helpful to, in a rational way, roll out those resources. So I think testing, which is also, of course, can be very focused, in contact tracing in one layer. And I think thinking about things that will be happening on the order of months down the line would be vaccines, and really better understanding vaccine acceptance by sociodemographic and racial factors. I think it's going to be important, and then being able to roll it out in an equitable way. So I think those are some of the near-term issues. And I kind of was taking notes. I think, Bill's already mentioned, I think long-term, there are a lot of structural issues that need to be addressed. And a lot of these do include, employment and education, things like that. But, one thing that struck me, just being in healthcare sales, there are some things that are modifiable on a month-to-year time frame. And I think I was struck by, Bill, the paper out of Louisiana, published in New England Journal in June, that looked at Black versus white severe COVID mortality. And basically, it showed that although there was a difference between Blacks and whites when it came to unadjusted mortality, that once you factored in things like obesity and other comorbidities, that racial disparity disappeared. And it made me wonder about just the opportunity that you may have with your data looking at the Hispanic population, which I don't think has been very well described in other areas, as whether there's an opportunity to do something similar, to look at the impact of comorbidities, which, arguably it's difficult to get people to lose weight, but it's doable. And I've had a few patients in my clinic who I've basically said, look, this is the time now, if you've ever thought about it, to really try to lose weight. And many people can't, but some people actually have been able to do it.
I was going to speak about a precursor to this work, which, a magnificent response on the part of Cook County and Bill and team. Bill, you were involved in the homelessness project. I think I'm right, and I'm thinking about the preparation that gave you for this particular crisis. That you were able to link into the homelessness information system, that you had gained the trust of at least an advocacy organization for that community and so on. Would you say that that's true? I mean, am I portraying this correctly?
Yeah, that was that was very instrumental, and it wasn't necessarily the analysis that we did or the data sharing that we did. It was the relationships that formed from that project. I'd like to think that the data really informed what we did, but the system's really difficult to get data out and to link the homeless system. So, but the relationships endured and created an opportunity where we could work together, particularly with the city Department of Family and Support Services that has been making investments in finding housing. But it was easy to pick up the phone and call and actually work with public health to get this off the ground, which again was amazing that it came through in a pretty short period of time. So I wish it were more about the data, but it was not. It was relationships, and you probably know that's the data. That's just a tool for the real work. That's the collaboration that's occurring.
Absolutely.
We did do something I thought was going to be helpful. I'm not sure it was, but we had the addresses from all homeless shelters, and we had a real-time feed of people showing up to emergency department and getting tested for COVID. And then we would push that to the health department. So we did do an informatics solution that didn't scale beyond our institution. And my sense is that it was public health was so overwhelmed at the time that I'm not sure it made a big difference, because every congregational living facility felt like a hot spot to them. But it was kind of a novel kind of feat that I thought was going to pay off. I'm not sure it did.
I was just going to say, I know we've touched a little bit on policy, and there is a question in the chat box someone has posted. To what extent does national policy or lack thereof play into equity challenges for COVID in Cook County?
Yeah, this would be, I'm not sure you have any policy wonks, me included, on the panel, but I mean, certainly things come up, but when you think across those domains, and I think Sean was going to say something, but if I'll just, I mean, some of it is the structural problem. So why do we have obesity problems in some of our neighborhoods? Is the disinvestment that we've talked about creating environments that make it hard to stay healthy? And I think we all know the answer to that. Is the mistrust in the government over generations of either disinvestment or inequity cause mistrust that makes it hard for them to say, yes, I want to be the first in line to get vaccinated. And then policies certainly around work environments and healthcare are critical and need national leadership. But I don't know, Dr. David, if you had comments or others.
Yeah, absolutely. First of all, I'm in awe of what you and your team were able to do in terms of the community of solution approach, where you had healthcare, public health, charities, Salvation Army, YMCA, social services, boots on the ground, clinical work, as well as the shelters. And that model, if it could be canned and scaled up across Chicagoland, I would think would be very powerful. But the things one can't can are those relationships, the trusted relationships that Cook County's built with the communities. So, but I'd like to just ask you all to kind of maybe stretch to think, what could that be? You know, what if there was going to be a new scaffolding that would link together the health systems across institutions, as well as the public health infrastructure and the community engagement that's been happening with Chicago, Alliance Chicago, and other things. If you had $1 billion, how would you invest that to build that, make this permanent? Because you touched on some areas where you have obesity, diabetes, things, chronic diseases that are common. That takes prevention as well as standing up these acute approaches. So I just wonder what you're thinking. What in terms of what could it be? How to scale it? Because we need it. You know, there's so much fragmentation.
We do have available in McCormick Place Hospital. So if you're looking for a physical place, that doesn't give you necessarily the programs, but it's a place to house the programs, particularly during this next surge. And I'm guessing the next surge, people will not be as sick. The mortality from COVID the last month in Illinois is 1%, compared to maybe 5 or 6 times that at the beginning of the pandemic. And so it may be possible to care for a larger number of patients in a less intense environment. And McCormick Place was built, or the hospital was created there. It hasn't been used very much, but it does seem like it would be a great opportunity to try to implement some programs in a large physical space like that, particularly for people who are maybe mildly ill and require care, but don't need acute care, like don't need access to an ICU.
Mm-hmm. So that really segues to this other question about what are the implications of the research for healthcare dissemination and implementation. So there are bricks and mortar resources. There's a lot of data about social determinants of health and their impact on COVID-19 outcomes. So thoughts within your health system and others, how do we learn quickly from this and apply it to implementation in our health systems? For example, food security in food deserts, or clearly there's a great example of MAT for opioid dependence. Are there thoughts about dissemination and implementation?
Coming from a CDC background, I always think of trying to measure what it is that you want to change. And one of the early steps would be a standardized way of assessing some of these among our populations. I know that NorthShore, I've had personal experience with that. As you come in and get screened and you fill out your health history, you probably ask some of these questions. I know it's done in different ways across the health care systems, but understanding housing instability, understanding who has food insecurity, who has literacy challenges. As a clinician, we've tried to do some of this, and myself, I can understand the frustration because you have a short visit and you're trying to address all the medical problems, and then to throw in social problems makes it overwhelming and sometimes I think demoralizing to hear about these problems and not have any tools to fix it. And possibly for the patients too, to tell someone, hey, I'm homeless, and that's, well, there's nothing we can do. But I do think measuring it and understanding it is a first step, and then advocacy for how we can try to solve some of these problems. We do have a food truck that goes out to neighborhoods. We're trying to do things like provide food in certain neighborhoods. Other institutions probably do similar things, but it would be nice to be coordinated. I do think that coordination is best come from a neutral entity, like a government entity that can assemble a group of at least the willing, rather than mandate, but at least starting with public health, trying to mobilize a response.
At the state level, would you say, or combination? State,
Yeah,
local, federal.
Well, a lot of it goes back to relationships. We have the Cook County Health Department, but it's suburban Cook County, and the city takes care of a lot of our most vulnerable individuals now. So I do sometimes feel like even local public health has this in their strategic plans. So Chicago in particular is going to roll out their strategic plan 2025. I'm not sure if suburban Cook County has the same strategic plan that they plan to disseminate, but I know that there's an emphasis on addressing the social determinants of health.
Thank you.
There's an unspoken element that we haven't mentioned, that at the same time as the pandemic, we've had what's been described as an infodemic, and probably more accurately, a misinfodemic. And some of the issues that have arisen and some that are going to arise, for example, trust in vaccines, is going to be vastly affected by this. Now, I know policy is a later bullet for discussion, but let's face it, we've had 4 years in which science has been not just downgraded, it's been denigrated, it's been dismissed, and has played a very small part in policy formulation. There's a great deal to be done there to reverse that. And of course, we have a crucial election coming up, but which way that election goes may determine whether we can do anything about this.
Absolutely. And related to that, there's another question or comment from a participant. So it's from Sarah. I can't see the full name. Polonsky. I imagine that a large part of the inequity would be tied up in the way that we approach immigration and people's limited options as undocumented residents in this country. Providing sick time doesn't help a population that is employed in less traditional work environments or work that doesn't come with benefits. Any comments?
Yeah, I'm glad that comment was made. I completely agree. When I thought about this is, we've talked about this for so long. It's fixing our immigration, work visas or something to make, to have a workforce that wants to work here and do so under certain regulations and guidelines. And yeah, I think that's critical for our country.
It also, the workplaces weren't made safe enough. So if you look at the meat packing and the slaughterhouses, there were simple things that could have been done in terms of UV lights, face shields, masks, gloves. There were very easy fixes that were well known from an infection control standpoint that were not applied, not even late. They just weren't applied. And so, plus I think that a number of the transmissions occur in break rooms when people are eating, and even if they were given personal protective equipment, they really weren't instructed about how to use it in a break room. So you go in a break room and everybody's sitting a foot apart and takes their masks off and starts eating away. And so I think there were a lot of simple fixes, and going forward, those need to be applied for the next wave of the pandemic to make workplaces safer for the people who must work. and must work in environments that have certain inherent risks that are mitigatable.
Bob, this is Mike. I've been trying to follow some of that from IDPH presentations, and it seems like those workplaces from an outbreak standpoint have gotten better, but I don't know the answer to this. Do you feel like they have started to really implement those needed changes for masking, et cetera?
I really don't know. I think we'll see is what the rates are and who gets sick in the next wave. Chicago's meatpacking, the Ashland Avenue meatpacking plants are, the stockyards aren't really in service anymore. So it's probably more in other states, Iowa, Nebraska, and so forth. I think our back of the yards is not very active right now in terms of slaughterhouses. Maybe other people know more about it. You can still smell them though, but I think that'll go on for decades.
Yeah, no, they're definitely more in the rural or expert areas of the state. I think Illinois still has, just hearing some of the presentations, still a fairly active industry for that.
Yeah. But also getting back to Dr. Solomonides' comment about trust in vaccines, that we have a seminar in December from Dr. Novak from UIC about vaccine research. But part of this is it sounds like politics are part of the problem. But also in terms of policy, how do we make sure that we can provide equal access, overcoming the fears of immigration status and issues around health literacy and other factors? We have a lot of issues to work out quickly, as I think through phase 3 clinical trials, but then eventually in implementation. So thoughts about policy, federal policy, for example, that really prepare us for inoculating ourselves against the most severe kind of second wave that we could hopefully not get.
I think from my standpoint in communicating vaccines, that there's a scientific hurdle to get over, and those are what the clinical trials are and the FDA approval. But then there's just as importantly, if not more importantly, is the political aspect and who do people actually turn to, who do they trust for vaccine safety. So I think there is a need to figure out for various populations who are the best spokespeople for that. I think my inclination is always to trust public health, and we have great representatives at all levels really in our state, I think, being able to lead that effort. And I think they will be the spokespeople, as well as I think people who are appointed as hopefully work groups who are able to also speak to the validity of the studies. But I think that's a missing piece still. It's probably from a vaccine education standpoint, who are the influencers of vaccine safety?
There's a technical issue as well. I understand. I'm not an expert in this, but I understand that vaccine distribution is going to present certain challenges depending on whether how deeply frozen the vaccines have to be when they're being distributed and so on. I've seen some exchanges concerning whether we have a system in place, and I understand the military may be brought in, but I don't think it's a solved problem yet.
Right,
Yeah.
and how do we have public access, even for patients without access to healthcare, to vaccines if we're going to vaccinate 100 million people, 200 million people? There's a major mobilization effort that would be needed. So there's a lot of policy applications of this going into the future. Dr. Solomonides, do you have another comment?
No, absolutely. I was just agreeing. I mean, I hope that more work is being done behind the scenes than has been visible, but other areas do not give you confidence.
So let's talk about the communication strategy from public health, and maybe this is a good test case Does the panel feel like there was good coordination between the city, the county, the state, in terms of communication strategies for testing, social distancing, and other access issues? So what could be learned going into the future?
May I speak as a non-citizen? the remarkable thing is how well states have done in, within states. I think by and large, they've done admirably well. But go above the state level to the federal level, and it becomes such a mess that you wonder whether, anything will be brought together.
Yeah, speaking of which, there is a comment in the chat box. I wonder to what extent national government oversight or policy change could help address some of those workplace safety issues, such as within the meatpacking industry. Relative lack of accountability for large companies comes to mind as one source of problems for COVID in our country. I couldn't agree more. I think accountability is a huge factor in ensuring there are appropriate infection control measures to prevent the spread.
Absolutely. So that is complex because of governance and what does accountability mean in terms of inspections and consequences of violations, but
Yeah, this is
needs to be addressed.
this is Mike. I think most of the power that I've seen for accountability has come from the state level, and Illinois Department of Public Health, for example, having the power to be able to shut down a factory, at least have that threat hanging over a factory when an outbreak occurs. So I agree with what Tony said. I think that, we've had experience, I think, working together with other outbreaks, for example, multi-drug resistant organisms. We've seen a lot of great collaboration at the state and local level for public health. And I think I'm very complimentary, I think, in saying that from the government, state government and the governor on down, it's been really a consistent message for public health and what people are supposed to do for COVID. I think that's helped us tremendously as a state.
So it seems that there's been good coordination between the city, the county, and the state. Very good. So moving on to the final discussion question, what are the implications of this research for future translational research directions? Dr. Trick, you showed some cluster analyses that were very informative for not only the Cook County or Rush catchment area, but all of Chicagoland. Where does this work go next in terms of the analyses that could be done? And also, Dr. Solomon, I'd like your thoughts about that.
So I had a very, not a core thought about this, but thinking specifically about informatics, what can informatics contribute? And I was very impressed and saddened by a very interesting article by Kristen Schorsch from WBZ on inter-hospital transfers at the height of the pandemic. And it seemed remarkably difficult how personal contacts had to be used, phone calls, difficulties of transferring to McCormick. I mean, a huge array of issues were raised. And the article is still online, it's worth reading. And I would have thought that informatics could contribute significantly to a solution of this problem. It's a matter of information, and it's a matter of agreeing how that information would be collected and shared. And it's even going out and writing a very well-informed article you can see the gaps in the information even there. For example, in the case of NorthShore, they identified 900 transfers, but they realized that some were transfers to Glenbrook, which was our COVID center. Some were transfers of patients, non-COVID patients, to other hospitals for more appropriate treatment and so on. And this, they didn't disaggregate this. So it's a huge informational job to be done there to solve a problem that really could well arise again.
Yeah, and now there's a lot of innovation that could, if we can work out the bioinformatics roadblocks, give a lot of extra knowledge about contact tracing using mobile health data, right, and viral genomic mapping and tracing different clades across different neighborhoods.
Yes.
Yeah, I think about what is happening down in Champaign with the University of Illinois and what they did in the summer to prepare for students, and kind of a phenomenal job in bringing together computer scientists, modelers, epidemiologists to try and solve this and develop their own test. And so I realized they had problems with clusters early on. I think because they said they didn't expect people who were positive to not adhere to the quarantine recommendations, but knowing, like you mentioned, the informatics solutions, who were your contacts of someone who tested positive, testing people once or twice weekly. You can't get into a building unless you prove that you were tested and negative. And some of these kind of really fall into the challenge of, are we protecting privacies? And we have a much different country than some of the countries that did similar things and controlled it. But if you, the privacy is extremely important, but certainly if you're thinking from a public health perspective, there are those public combination of testing, rapid testing, and rapid turnaround of who did they contact, and then having a place for those people to go. I think we'll see some papers from these little small regions that were able to do stuff like that, not just countries but the regions. And I'll be very interested in what happens. I think, like I said, the University of Illinois and Champaign was pretty advanced to write their own programs and set this up. And the other thing is the mobility data that I showed in the one slide, that we can track how mobile a population is and in what states did mobility drop and where did it not. Those data are mine to look at whether the public health information is working.
So you bring up a really great example. I was thinking about Big Ten football being enabled by this regular frequent testing, and that's U of I and Northwestern. It's our neighbors in Michigan and Iowa and so forth. But I wonder if tapping into university resources like that could be a good synergy with public health. And maybe that's already happening, Dr. Trick, as you brought it up. But that's a great test case. But I think it's well resourced around maybe a smaller population, but still, how could we get that here?
Yeah, so I know Pritzker early on engaged the academics and made his decision to shut down early based on information from those scientists who said, if you don't shut down now, this is your window. And this is right after New York. And I think he acted quickly. And although it got bad here, I think he prevented worse things by engaging with academics, modelers. I know Northwestern was involved, University of Chicago, University of Illinois, and Champaign. So it does help, I think, to have the scientists, advising you and listening to them.
Absolutely. And just also just a pitch for Chad Konchak, our data analytics lead here, worked a lot with Governor Pritzker, and NorthShore did, I think, maybe the plurality of the testing. So there was a lot of information that fed into the statewide data about tracking of incidents and outcomes. So these loops are happening. They are definitely there and very informative. And it'd be amazing to bring it all together in one big multi-layered sphere of integration to prepare for the next pandemic. But I think that there's a lot of well-laid tracks and relationships and trust in the public health community. That's very clear from your work. Are there other thoughts from the panel about translation of research directions? Dr. Lin?
Yeah, as I'm thinking about just how do we translate what's known about COVID into action, I think I still kind of think about just the research about acceptance of public health messaging. Even though we have consistent messaging in our state, are there still barriers that prevent people from really hearing and adhering to things like mask use or vaccine use? And so I think those are critical for this pandemic and for future pandemics, if we're going to be able to translate what science learns into real public health gains. And so I think people are doing this, have done this, and continue to do this, like survey-based outcomes research, looking at how people receive their public health data, how they interpret it and react to it, and who are some of the best influencers of that. I think, and this is outside of my domain, but I think this is where I think social network analysis and things like ideas are able to really, I think, benefit public health.
Absolutely. So we need big data as well. Our next seminar is going to be with David Allen Drew from Mass General, where he's part of the team where they started the COPE consortium with a symptom app, and it has a lot of questions about how people contracted it, their symptoms over time, but over 2 or 3 million downloads internationally. So there's a lot of data from different nations and different regions. It could be very informative too, overlaid with the state and local data. So we welcome you back for the next seminar. Please feel free to join and stay involved. So we do have more time. I do want to kind of give some overall comments on this really extraordinary work that was presented today. I was thinking about the Blumenstein article for 2008 on disparities in pandemics. And you listed the factors that contribute to disparities. So one being differential exposures, another being distrust of governments, another being limited access to medical care, and then another susceptibility to comorbidities to chronic disease, particularly diabetes and obesity. And looking at the work you presented today, it could not be more apropos to what we have just gone through and what we're still dealing with. And yet the answer, this is not coming from me, but I've seen that Dr. Fauci or Birx said that is community. That, like with the AIDS epidemic, community organization, leadership, trust, you have that, you've built that. And I'm just inspired by what you've been able to do, not to claim victory by proxy, but just to say that that's a really wonderful example and lesson for those studying public health to see what public health can do, bringing all these stakeholders together. So I just want to thank you as a citizen of Illinois, resident, for this leadership. And I think that I hope that we can take a lot of this and apply it in the future towards preparedness, and really to some degree use this as a model for other state laboratories. And so I'll just, we still have time for more comments or reflection, but I really want to thank you all for your very thoughtful comments, for your really brilliant presentation, Dr. Trick, and to the panel, to Dr. Weinstein and Dr. Lin, Dr. Solomonides, and to Rabia for organizing so much of this, and to Rachel for keeping this moving.
Just a thought about another possible lesson from this.
Please.
Looking back, there have been other epidemics, and indeed there have been very, very eloquent warnings. The 2018 Shattuck lecture by Bill Gates is an amazing lesson in how, and so prescient in what may happen in a pandemic, even starting in China, funnily enough, but that's incidental. And the question I would ask is, why have we failed to heed any of these warnings? The pandemic has hit us as if we had never thought of having a pandemic before. And maybe there is a lesson there.
If you read Winston Churchill's speech from 1936 to the British Parliament, it's called something about the equity of air control. He says it falls into the unteachability of mankind to apply too late those fixes which, if applied at a proper time, would have avoided disaster. So that's 1936. So Google Winston Churchill and unteachability of mankind. It's a great speech, and it addresses exactly what you're saying, Tony. And it goes back, I guess, centuries back, and unfortunately it'll probably go centuries forward, but I think it's an important point. So Google Winston Churchill and unteachability of mankind, and you'll get a great speech.
Thanks.
Thank you. I love a good Churchill quote.
Don't make me feel at home. Yeah.
Lovely. Okay. Could we advance to the next slide? Very good. So in closing, thank you for joining us today, to our speakers, the panelists, everyone who contributed. For questions, comments, concerns, or requests to present at a future seminar, please contact me directly. My email is right there on that slide. If you could all please take a brief survey regarding today's presentation, it would be really appreciated. We do actually read every single response, and it really does help us make this better in the spirit of continual quality improvement. You'll be directed to a slide after you close out of the window from Zoom, and the link is also in the chat box. Our next seminar will be held on Tuesday, November 17th from 3 to 4:30. Dr. David Allen Drew from the Massachusetts General Hospital and Harvard Medical School will be joining us to present the COVID-19 symptom study, real-time epidemiology using a smartphone app during a global pandemic. And lastly, the recording of today's webinar will be distributed in a few days. It'll be posted on YouTube, as well as previous seminars. So thank you all again, and have a great rest of your week.
Thanks, Sean.
Great. Thank you.
Thank you.
Thanks.
Okay. Rabia. Okay, I'm just going to also say, just a reminder, please take a moment after the seminar to take the brief survey, which is in the chat, I believe. Let me just double check that.
It is.
Okay. All right, very good. Thank you all.
Okay, goodbye.
Bye.
Bye.